Hello, everybody. Let's jump into chapter 78. This is miscellaneous antibiotics, which I love because we have three classes of drugs that don't fit into any of the other categories, so they all get lumped in together. We talk about the fluoroquinolones, the midazoles, and the cyclic glycopeptides. So your book, Laney's, jumps in first to the fluoroquinolones. These are really great drugs that probably, again, got overused in the beginning, and so we do have some susceptibility issues and some resistance that has flourished. They're highly effective. They have many advantageous pharmacokinetic properties. They have really high oral bioavailability, which is one of their strongest suits. They're a broad spectrum antibiotic, and then you also have high oral bioavailability, so they make it very advantageous to use these to treat harder infections in the outpatient. They also have a really large volume of distribution, so they're a very effective drug to give. The big problem now with the fluoroquinolones is that we've learned a lot over the years, and they do have some serious adverse reactions, potentials, and they have multiple drug-drug interactions. So the theory of practice is we use the fluoroquinolones when the benefits outweigh the risks. That's not always the way that it used to be. Back in my day when I grew up as a young provider, we were giving fluoroquinolones pretty freely, I would say. And now that we know more, there's really more of a restricted use for it, which is why in the previous lectures about urinary tract infections, I've said this is not the first drug of choice that you would go to because of the potential adverse reactions. This one talks a little bit about the tendon rupture that is considered a low risk, but it is the black box warning of the fluoroquinolones. And so you do need to know that. That's something that's going to pop up on test questions or board certifications down the line. Definitely in your decision and management courses, that's something you're going to have in the back of your mind. They're risk to all patients, but especially those that are older than 60, those that are taking steroids, and those who have undergone organ transplantation. And we typically avoid them in those less than 18 years of age. So there's benefits and risks of using the fluoroquinolones, and Laney's talks a little bit about this in a little more detail, but I'm going to go into it even in more detail because I do think it's really important for you guys to understand out in practice. The risks of the fluoroquinolones typically do outweigh the benefits for uncomplicated infections. So I'm going to say that one more time. The theory now is that the risks of using a fluoroquinolone outweighs the benefits for uncomplicated infections. And that's kind of standard across the board. So in other words, none of your societies or critical care medicine or infectious disease societies are going to support for simple uncomplicated infections that your first drug of choice is a fluoroquinolone, because the benefit does not outweigh the risk, and we typically will always have other antibiotics that would be as effective for simple, uncomplicated infections. When you're treating more severe infections, then you have to consider that possibly the benefits may outweigh the risks at that point. Generally, these drugs are pretty well tolerated, and that's why they were in use so much, as they were very effective and they were pretty well tolerated, but they do have the potential to have the adverse side effects. The GI and the central nervous system adverse effects are estimated to be 3 times more common with the fluoroquinolones than any other antibiotic class, and the incidence of the C. difficile infection appears to be higher with the fluoroquinolone use when compared with other antibiotic classes as well. So when equally efficacious and narrow spectrum options are available, you tend to select something else over the fluoroquinolones. Okay, so they do have these potential really severe adverse effects to include tendinopathies and tendon rupture, but it can also cause peripheral neuropathy, QT prolongation, and putatively aortic dissection and rupture. So let me add the slide here so you guys can have this written down of these potentially adverse effects. So again, they're the tendinopathies, tendon rupture, peripheral neuropathy, QT prolongation, and aortic dissection and rupture. The hard part about it is that the tendinopathies and the neuropathies can be permanent and disabling for your patients. So those are really big adverse effects. Also, the QT interval makes them tricky to use. The aortic dissection and rupture is very rare, but it has been associated with it, so that's something that we would take into consideration. So even though it's very small risk, the FDA warns against fluoroquinolone use in patients with known aortic aneurysms, and those with people that have like severe peripheral vascular disease, uncontrolled hypertension, or really advanced age. So you really have to do the risk-benefit for those patients. To take into consideration for pregnancy and breastfeeding, the fluoroquinolone should generally be avoided during pregnancy and during breastfeeding. Fluoroquinolone use in animal models during pregnancy has been associated with bone and cartilage toxicity in the developing babies. So while similar effect has not been observed in humans, we do apply that, and so we say don't give them in pregnancy. For children, the risk of musculoskeletal toxicity is too high, so they're no longer really recommended at all for children, so 18 and older. And then the other effect that we've come to realize with the fluoroquinolones is that you should not use them in patients with myasthenia gravis because they have the neuromuscular blocking activity that may precipitate a myasthenic crisis. So we've now seen in those MG patients that there's been reported death and respiratory failure because someone received a fluoroquinolone that had myasthenia gravis. So the second black box warning for the fluoroquinolones is to caution use in myasthenia gravis. In your book, if you go to table 78.1, they do talk about the different systemic fluoroquinolones. The gemafloxacin, I do not have a lot of use or experience in use. The delafloxacin, Baxdela, I also have not seen in practice. The main three most people consider is ciprofloxacin, levofloxacin, and moxifloxacin. And then ofloxacin is something that I've seen in practice as well. These drugs can have interactions with things like antacids, calcium supplements, milk and dairy products, and then any of the salts, as well as caraphate. So you're probably going to see some kind of drug-drug interaction when you do go to prescribe these. The book talks specifically about Cipro as the prototype of this drug. They talk about the mechanism of action is that the floxacin drugs inhibits the two bacterial enzymes, a DNA gyrase and a topoisomerase. Both are needed for DNA replication and cell division. So in other words, you're interfering with DNA replication and cell division in their mechanism of action. Ciprofloxacin is rapidly bactericidal. So again, we know that we prefer to have bactericidal drugs instead of bacteriostatic drugs, so that you can see why these drugs would be used in abundance initially when they came out. They were very effective, they killed off a lot of things, and they were available as oral drugs, but now we know we have to use them much more safely. You can again give the Cipro IV or oral. They still don't cross the cerebral spinal fluid well. We use the floxacin drugs for a wide variety of infections. Typically, though, we think respiratory tract for pneumonias, etc., GI tract or urinary tract infections. They're also great for bone, joint infections, skin, and soft tissue infections. The other interesting thing about Cipro, and specifically, is that it's the preferred drug for preventing anthrax in people who've been exposed to anthrax spores. So that's kind of a unique property of that. The other one is that we don't typically use ciprofloxacin for staph infections because we have developed fairly high rates of resistance. The book does talk about there is 2 approved pediatric uses, but again, for the purpose of us generally speaking, we would say that they're really rarely used and mostly avoided in pediatrics. The way that the tendon damage happens, we think, or we theorize anyway, is that we disrupt the extracellular matrix of the cartilage, and that way we weaken that cartilage and you can have a tendon rupture. Because the tendon injury can be reversible if diagnosed early, fluoroquinolone should be discontinued at the first sign of tendon pain, swelling, or inflammation. So this is a big teaching point for your patients, is that if you do prescribe a fluoroquinolone, with that should come the education of reporting any tendon pain, swelling, or inflammation. Patients should also refrain from exercising if there's any concern about the tendinitis. The Cipro and the other fluoroquinolones also pose a risk for phototoxicity, which is the severe sunburn. So you have to educate patients on that as well. If they develop a burning erythema or blisters or severe edema with swelling, that can be a sign of an adverse effect from the drug. You do tell people to avoid long, prolonged direct sunlight or sun lamps or indirect sunlight without having heavy-duty sunscreen. The other thing about it, again, we talked a little bit already, is the C. difficile infection. They're highly associated with the fluoroquinolones. So part of your patient education is going to be discussing C. diff and when to report frequency of stools or watery stools. And then specifically, some of the fluoroquinolones also have that potential for QT prolongation. So you may need to monitor for that depending on what other drugs they're on. The next class of drugs that they refer to is specifically metronidazole. I'll give you a slide there for that. Trade name is Flagyl, which we still commonly use, and that's used to treat protozoal infections or other infections caused by anaerobic bacteria. We'll talk a lot more about it in chapter 83 when we talk about protozoal infections. But in terms of using it for an antibacterial properties, we know that it is lethal to anaerobic organisms only. So that's a little different than some of our other antibiotics. It can exert bactericidal effects, so it can also be a very effective antibiotic against anaerobes. But it must first be taken up by the cells and then converted into its active form, and only anaerobes can perform the conversion. So the active form of the metronidazole will interact with the DNA to cause strand breakage and loss of structure, which results in inhibition of nucleic acid synthesis and ultimately cell death. So therefore it is bactericidal. Because aerobic bacteria are unable to activate that mechanism, they are insensitive to the drug. So it's a very specific range of use as an antibiotic, but metronidazole we'll talk more about because we use it for protozoal infections. Typically, if you're thinking metronidazole for bacteria, we think of things in the GI, abdomen, bones, joints, skin, soft tissue, and sometimes GU. It also is a drug that we can actually use to treat C. difficile infections. So you'll see it lots in practice for a very mild C. difficile infection. We also still use it as prophylaxis in surgery. If you're having a surgery that's a high risk for an infection by an anaerobe, specifically it tends to be the colorectal or abdominal surgeries or the GYN surgeries. Also, we've already probably spoke about metronidazole in use of H. pylori treatment as one of the 3 or 4 drug regimen. It does carry its own black box warning, which is that it's been associated with increased carcinogenic risks in mice and rats, and so we shouldn't use it unless absolutely necessary. But it is used, it's a very effective drug, so we still use it quite a bit in practice. The next drug that gets thrown into this random assortment of drugs is daptomycin. The trade name typically is Cubicin. It's the first of the class known as the cyclic lipoproteins. Its unique mechanism and action can rapidly kill virtually all relevant gram-positive bacteria, including MRSA. So obviously this is going to be a drug that we're not going to give first line. This is going to be a drug that we reserve for specific use because we don't want to have this powerful drug develop resistance. Daptomycin is also devoid of significant drug interactions. So obviously that's a great unique characteristic of the drug as well. It's also given once daily by infusion, and there's no need to monitor plasma drug levels. So that's fantastic. The other drugs, though, that have since popped up with the cyclic lipopeptides are the dalbavancin and oritavancin, which is Orbactive, which is also kind of the newest, hippest drug on the market that infectious disease guards with their life. Daptomycin is also bactericidal, and again, is mainly working against gram-positive bacteria, including some of the anaerobes, but it's not active against gram-negative bacteria. So it is going to cover staph, enterococcus, streptococcus, corneobacterium, those kind of things as well. It's also not active against Mycobacterium. There is some beginning development of resistance already. So again, this is a very specific use type of drug. We think of use for it in bloodstream infections, endocarditis, skin, and skin structure infections. The greatest adverse effect would be myopathy, and it does really only interact with statins. When you do read up on current use of daptomycin, we do see it a lot for respiratory tract infections. We don't see it a lot in the use of respiratory tract infections because daptomycin tends to be inactivated by alveolar surfactants. So it's not a good choice for pneumonia and respiratory tract infections. We do use it for urinary tract infections for difficult to treat ones. It has a poor penetration into the cerebral spinal fluid. It's really good for skin and soft tissue because approximately 70 to 90% of the drug will penetrate into the skin and soft tissue. The big thing is, though, is that daptomycin should not be used for treatment of pneumonia or respiratory infections. The monitoring really should be for development of muscle pain or weakness, at which point we would check a CPK. If they're on a statin, some people will hold the statin while they're on the daptomycin. It does need renal adjustment. Specifically, they also talk about weight and whether or not weight-based dosing would be recommended for daptomycin, but the FDA still recommends that we use standard weight-based dosing for all patients. Remember that it's an IV infusion for daptomycin as well, and it has minimal metabolism, minimal excretion in the urine. So in patients with normal renal function, the half-life is 9 hours, but those with severe renal impairment, the half-life increases threefold. So you do have to renally dose these drugs. And again, the big thing when you think daptomycin also is the black box warning for muscle pain or weakness. So let's jump right into chapter 79. There's not as many videos to download. This is where we start breaking into antifungal agents. We divide these into two major categories, which is systemic mycoses or drugs for superficial mycoses. So we do kind of break them down that way. The drugs for systemic mycoses can be subdivided into opportunistic infections or non-opportunistic infections, and that we'll break that down a little bit more. These are more difficult to treat infections when it is systemic fungal infection. Oftentimes you have resistance to treatment, or you have to have such prolonged exposure to the drug that you can get these more toxic side effects. When you talk about opportunistic mycoses, we're thinking things like candidiasis, aspergillosis, cryptococcosis, and mucormycosis. And those are ones that are primarily seen in immunocompromised patients. So these are people that are on chemo, HIV, cancer patients typically are the ones we kind of think of that can get these systemic fungal infections that are really sometimes hard to treat. The non-opportunistic infections can occur in anybody, and those tend to be relatively common. And those are things like sporotrichosis, blastomycosis, histoplasmosis, and coccidioidomycosis. I can't say that one to save my life, never have been able to. Treating systemic mycoses can be difficult, and so we do have to talk about how you're going to dose these and how we're going to use them. But every time I have to prescribe one, I kind of have a sigh because they're just difficult. You're always going to have some kind of drug interaction. There's always some kind of complicating factor, it seems like, when I've used these in practice. It just never seems to be an easy drug to order, and there's always some kind of decision making with it. When you go to your table 79.1, they break them down into 79.1 and 79.2, which is really kind of nice to see it that way. So let's start with amphotericin B. And let's bring you guys into a new slide for amphotericin B. This is one of those other drugs that every time I've ever had to use it, I have a big heavy sigh. It's just difficult. It's difficult to use. It's difficult for the patients to tolerate, and it almost always has some kind of adverse effect or drug interaction. Amphotericin B belongs to a drug class known as Pauline antibiotics. Nystatin is another drug that's in that same category. Amphotericin is a very potent drug, and it works pretty darn well in terms of killing off the fungus, and it's active against a very broad spectrum of fungi. And so it's almost always a good drug of choice for a systemic mycoses. So remember, though, the systemic mycoses that are the complicated ones in immunocompromised patients, those are the ones that end up needing amphotericin B because they get some kind of opportunistic systemic fungi. And so then we really need to pull out the big gun of amphotericin B. But now we're using amphotericin B in a class of people that have multiple other things wrong with them and they're very ill. And that's where the complicating factors come in with this. It's tough to use them in people that have all these other issues going on. Big thing when you think of amphotericin B, honestly, you guys, is that it's highly toxic. I mean, there's no other way to say it. So it works really well if you can manage to stay on the drug. The big ones for toxicity, when you think of amphotericin B, you have to think of renal damage in patients, and I'm talking about damage sometimes that can be irreversible. And then it can have a significant infusion reaction that make people feel really crummy. So because of its potential for harm, it is only employed against infections that are progressive and could be potentially fatal. So when you think amphotericin B, we're thinking really sick people that have a really bad opportunistic fungal infection, but we have to choose to use this drug because the risk versus benefit. The benefit of the drug outweighs the risk of death. Okay, so this is not something that you're going to give somebody with a yeast infection. This is something that you're going to use in the ICU with really sick people. It's also something you're probably only going to give when you are using it with the help of infectious disease. It actually comes in 4 formulations that the book kind of talks about, and 3 of them are lipid-based. The lipid-based are much more used in practice now because we found that they are less toxic and less of a risk for infusion reaction, but they are much more expensive, of course. All of these formulations of amphotericin B are only given IV. And again, these are medications that people have to be on for months, typically. And so if you have a highly toxic drug that can cause some really bad reactions and you have to be on it for a long time, it's like, I don't even know how many times I've seen somebody actually be able to finish their course of amphotericin B. The way that it works, its mechanism of action is it binds to the components of the fungal cell membrane and increases permeability. Again, whenever we disrupt the integrity of the cell membrane and it becomes more permeable, then we're having leakage of the intracellular contents. And so then the cell will die. Depending on the concentration you're able to reach of amphotericin B and the susceptibility of the fungus, the drug may be fungostatic or fungicidal. So if you are able to tolerate it at the high enough doses and not have toxic side effects, it oftentimes can be fungicidal, which is of course what we would prefer, especially in an immunocompromised host. But otherwise, even at lower doses and lower concentrations, it often can be fungostatic. Much of the toxicity of the amphotericin we think is attributed to the presence of the sterols, which is principally cholesterol. And so when amphotericin binds with cholesterol in us as mammalian members, the effect is similar to that's seen in fungi. But we know that the fungi are affected way more than we are, but there is a degree that we're affected as well, which is why it's so toxic. It is a really useful drug, and it has a really broad spectrum of what kind of fungi it's going to kill. And it also kills some protozoa. There are, the important point too is to remember though it's bacterial resistant. This is not an antibiotic, this is an antifungal drug. So again, it is the drug of choice for most systemic mycoses, okay? This is the kind of drug that's needed because before we had amphotericin B, people that had these fungal infections like this, the systemic intense fungal infection died. So now that we have amphotericin B, and if you can stay on it and do it, we've had much better outcomes and people can survive when they have immunocompromised systems that get a systemic fungal infection. Most times it's at least 8 weeks that you're on treatment. Sometimes it's up to 4 months. It's poorly absorbed from the GI tract, so it's only given in the IV route. When the drug leaves the vascular system, it undergoes extensive binding to the sterol-containing membranes of tissues. It does not cross the CSF. We actually don't know much about the metabolism and excretion of amphotericin B. Renal excretion of unchanged amphotericin is minimal, but renal reduction may be needed for people with pre-existing renal impairment. Complete elimination of amphotericin takes a really long time. In fact, the drug has been detected still in people's tissues more than a year after their last dose of amphotericin B. Of course, then it's going to have a black box warning because of its toxicity. It should only be used in the potential life-threatening situations. This is literally the drug that you would give to a patient. You say, this can be highly toxic, but if I don't give it to you, I think you're going to die of your fungal infection. All right, so let's talk a little bit more about what these issues are. The first one is an infusion reaction. So just by giving the drug itself, you can get an infusion reaction, which is not the same thing as a true allergy. You can get fever, chills, rigors, nausea, and headache. This is actually from a reaction of the pro-inflammatory release of your cytokines. So tumor necrosis factor, your interleukin-1, interleukin-6 from the monocytes and macrophages are released. And so you get this kind of fever, chills, whole body reaction, and people can feel horrible. Symptoms can begin within 1 to 3 hours after starting the infusion and can persist for an hour. So typically you almost always will proactively treat with diphenhydramine and Tylenol, just to kind of settle down the cytokine storm that you're probably going to release by giving the drug. But if those measures fail, you can give hydrocortisone, but that is less advantageous because glucocorticoids can further reduce your ability to fight your infection. So we try to avoid that at all costs. Remember that infusion reactions tend to be less intense with these 3 lipid-based formulas that we have. So those are typically what you're going to see in use, but they're really, really expensive. The other thing about amphotericin B is it is highly, highly, highly irritating to the veins, and so it causes a really high risk of phlebitis. So peripheral sites should be changed often, and if you can, going through a large central vein and pre-treating with heparin is what is recommended. So it's even toxic and difficult just to actually physically give the drug. For people to tolerate the infusion and for the veins to tolerate the drug itself can be tricky right away. So if you're giving it peripherally, this is something that I've literally had a new peripheral site each day. Well, that gets really tricky if you're on a drug for 4 months. So most people are going to end up with some kind of central line that has to be monitored very closely because it can be even irritating to that. So that's the infusion reaction part. Just to actually infuse the drug for the patient to tolerate it and for the veins to withstand it can be difficult right out of the gate. Okay, so imagine being on a drug that makes you feel bad each time you get it for 4 months. That's no fun. Second one is the nephrotoxicity. Amphotericin is actually truly toxic to the cells of the kidney, and renal impairment occurs in virtually all patients. The extent of the kidney damage is related to the total dose that you will receive or the patient would receive over the full course of treatment. In most cases, renal function normalizes after it stops. That's in most cases. However, if your total dose exceeds 4 grams, some kind of residual kidney impairment is likely. So that is, again, why we would say, I have to give you this drug or you may die, because it's probably going to be toxic to you in some way, shape, or form. We do know that the kidney damage can be minimalized by giving 1 liter of saline every day that you give the amphotericin. The other really important key to minimizing renal impairment is going to be avoiding all nephrotoxic drugs. So this is the kind of situation where I would say, don't even take an NSAID, don't even take 200 milligram of ibuprofen. We don't want to do anything that could also exacerbate your kidneys. To monitor that, you really do need to be testing their renal function every 3 to 4 days. And oftentimes they're in the hospital and we're monitoring intake and output pretty closely to make sure our urine production remains adequate. Other possible effects of amphotericin also include, because it's such a lovely drug, bone marrow suppression, so you can have an anemia with that. And then the other issue is that people tend to be on other drugs, and that if any of those can potentiate the possibility for renal issue, you have to decide what you're going to do with those. So amphotericin B, it's a gnarly drug. It works really well, and it will save someone's life if they can tolerate it, but it is only given basically in the hospital. This is not something that people are going to be on at home or come in for an infusion. That's very not regular. So these, unfortunately, are people that end up being in the hospital for 8 to 12 to 16 weeks for treatment of their opportunistic fungal infection. And the drug requires such close nursing care and monitoring just to have the patient be able to take the drug. So it's a very potent drug. The next one, I'll create a slide here for you, is going to be your azoles. And these are the ones we're probably a lot more familiar with in nursing practice. This is things like itraconazole, fluconazole, voriconazole, ketoconazole, anything of the azole drugs. So like amphotericin, the azoles are broad-spectrum antifungal drugs. They're an alternative to amphotericin B for most of the systemic fungal infections. They have a much lower toxicity, and they can most of times be given by mouth. However, they do have a disadvantage, is that they inhibit your cytochrome P450 drug metabolizing enzymes, and so they increase the levels of many other drugs. So again, people tolerate them pretty well. You can give them by mouth, that's great, but almost any time I have to give a drug that ends in azole, fluconazole, itraconazole, I have a heavy sigh in my heart because I'm bound to see some kind of drug interaction. It's like inevitable if they're over the age of 65 and you have to give an azole. Table 79.3 kind of breaks down what those drugs are and what their therapeutic uses are. The prototype drug for this is itraconazole, which is also known as Sporanox. The drug is safer than amphotericin B, and it can be taken orally, so that's a great thing. But it has the potential for adverse effects with cardiosuppression and liver injury. And again, it oftentimes will have some kind of drug-drug interaction. So, itraconazole mechanism of action, it inhibits the synthesis of ergosterol, which is a component of the fungal cytoplasmic membrane. So the result of impairing that synthesis, it shows an increased membrane permeability and leakage, and so we do see cellular death, and the cells become weakened, and then we can kill off the fungal infection with our natural immune system. It's again active against still broad spectrum of fungal infections, typically things like blastomycosis, histoplasmosis, sporotrichosis, and could possibly be aspergillosis, candidiasis, and coccidiomycosis. And it can also be used for the superficial mycoses. It comes orally. Food increases the absorption of the capsules, but decreases absorption of a suspension. So sometimes we give it as a suspension, sometimes it's in a capsule. That's an interesting trait of this drug. So if you are giving the capsules, they should take it with food. But if you're taking the suspension, it should not be taken with food. Administering it with cola, so soda, enhances absorption. So when it is absorbed, the drug is widely distributed to lipophilic tissues, but you don't get much in the way of cerebral spinal fluid. It undergoes extensive hepatic metabolism, and about 40% of each dose is actually excreted in the urine as inactive metabolites. Typical side effects to think of would be GI reactions, possible rash, headache, abdominal pain, or edema. But the big ones it could also cause is cardiac suppression and liver injury. The way that the cardiac suppression works when we're thinking of the azoles is that it has a negative inotropic action that can cause a transient decrease in your ventricular ejection fraction. Cardiac function returns to normal by about 12 hours after dosing. So if you have heart failure and you have to give an azole, you have to oftentimes have really close monitoring. Because of the negative inotropic actions, it should be really, really carefully given in patients with heart failure. And it really should be avoided. But if you have to give it, this is probably something that you would have to give in the hospital where you're monitoring their EF. But if they have a profoundly decreased EF, it's probably a drug you can't give at all. Also has a really rare history of liver injury. There's been some rare cases of liver failure that ended in death. So it's not 100% established if that was the case or not, but it now carries a sign that it could potentially cause liver injury, and so you should educate your patients about what that could look like. Some of the drugs that it will interact with, those are the CYP3A4s and the CYP450s. And so oftentimes the azoles will increase the dose of other drugs, specifically dofetilide and quinidine. And so if you actually give this with those drugs, you could get a fatal ventricular dysrhythmia. The other ones we have to really worry about, of course, are digoxin and warfarin, and then any sulfonylurea type oral hypoglycemics. If you're on cyclosporin or digoxin, you have to really monitor those levels closely. If they're on warfarin, you should be checking a routine PT-INR. You also have to be worried with drugs that will raise a gastric pH. So those are things like antacids, the H2 antagonists, or PPIs, because those can greatly reduce absorption of the oral itraconazole. So you have to make sure if you're on those drugs are taken at least 1 hour before you give itraconazole or 2 hours after. Because the protein pump inhibitors probably have a prolonged duration of action, the patients using PPIs may have insufficient stomach acid for itraconazole absorption regardless of when you give it. So sometimes I've worked with people that actually take them off the PPI for their length of itraconazole and put them on famotidine and dose it a little differently. We don't have good data about breastfeeding and pregnancy, so that's probably something I would always use with the advice of an OBGYN. All right, the next drug class we have then is the echinocandins. I never called them that either, so it's not a normal word for me to say. Echinocandins. All right, so this is our other class of drugs. They're the newest of the antifungals. In contrast to amphotericin B and the azoles, remember those two disrupt the fungal cell membrane. The echinocandins disrupt the fungal cell wall, and they cannot be dosed orally. So they're Antifungal spectrum is narrow, and they're limited to mainly Aspergillus and Candida species. We have three choices: caspofungin, mycofungin, and indulafungin. That's on your table 79.4 in your book. They all three appear to be equally therapeutic. Caspofungin is the prototype for the book. It was the first echinocandin available. Your antifungal effects result from inhibiting the biosynthesis of the beta-1 and the 3-delta-glucan, an essential component of the cell wall of some fungi, including Candida and Aspergillus. Caspofungin's IV therapy for invasive aspergillosis in patients unresponsive or intolerant to traditional agents of amphotericin or itraconazole. That's the first indication. Second indication is systemic Candida infections, including candidemia, so a blood fungal infection, and Candida-related esophagitis, peritonitis, pleural space infections, and intra-abdominal abscesses. The drug is better tolerated than the amphotericin B and appears just as effective. Caspofungin is not absorbed from the GI tract, so it has to be given IV. In the blood, 97% of the drug is protein bound, so caspofungin is cleared from the blood with a half-life of 9 to 11 hours. Caspofungin is pretty well tolerated. The times that I've seen this used, people tolerated it pretty well. Can cause some fever and phlebitis at the injection site, headache, rash, nausea, vomiting. Also, the caspofungin can be similar to the amphotericin in having kind of an infusion reaction or a histamine release. So some people get a rash, facial flushing, pruritus, or a sense of warmth. One case of anaphylaxis has ever been reported. Again, the caspofungin family can have their own drug-to-drug interactions, especially some of the AIDS or antiviral drugs, rifampin, dexamethasone, and phenytoin. Patients taking those drugs may need to have a higher dose of caspofungin. But caspofungin can decrease the levels of tacrolimus, which is a strong immunosuppressant, like typically after transplant. And combining caspofungin with cyclosporine increases the risk for liver injury. Okay. The next drug they talk about class is pyrimidine analogs, which is flucytosine. It's employed for serious infections caused by susceptible strains of Candida or Cryptococcus neoformans. Because development of resistance is common, the flucytosine is almost always used in combination with amphotericin B. It is taken up, its mechanism of action that's taken up by fungal cells, which then converts it to 5-FU, which, if anybody knows what that is a very strong chemo agent that we give, which is 5-fluorouracil, and that's a very powerful anti-metabolite. So the ultimate effect is the disruption of fungal DNA and RNA synthesis. So flucytosine is relatively harmless to us as humans. And so we don't have the enzymes that would convert it to 5-FU. The fungi do. Obviously, if it converted to 5-FU, we'd have a much different side effect profile. Flucytosine has a very narrow antifungal spectrum. It is fungicidal against Candida species and the Cryptococcus neoformans, but most other fungi are resistant. It is indicated only for candidiasis or cryptococcosis. If you need it for a serious infection like cryptococcal meningitis or systemic candidiasis, flucytosine should be combined with amphotericin B. It is readily absorbed from the GI tract, and it does penetrate well to the CNS, which is why it would be a useful one for cryptococcal meningitis. Adverse effects would be your bone marrow suppression, such as reversible neutropenia or thrombocytopenia. Rarely fatal agranulocytosis has been reported. It also has the potential for hepatotoxicity. Flucytosine should be used with extreme caution in patients with renal impairment, and that's actually its black box warning. It does have the potential for drug interactions. Oftentimes, remember, it's given with amphotericin B, so that is both good and bad. Because amphotericin B is nephrotoxic and because flucytosine is eliminated by the kidneys, amphotericin B-induced kidney damage may suppress the flucytosine excretion, promoting flucytosine toxicity. So it's important if they're on the amphotericin, obviously we're very closely monitoring their renal function. Flucytosine also can raise levels of other drugs such as dofetilide and quinidine. Those are antiarrhythmics, so you have to be careful. All right, so we have covered the drugs for systemic mycoses and infections. So now we can move on to the drugs that we would use for superficial mycoses and infections. Note that the azoles and the are both in both groups. All right, so the next drug when we talk about for superficial mycoses, so we have two groups that are considered superficial, Candida and dermatophytes. Candida infections usually occur in mucous membranes and moist skin. We know this from bedside nursing. Chronic infections can happen on your scalp, your skin, or your nails. Dermatophytoses are generally confined to the skin, hair, and nails. Superficial infections with the dermatophytes are more common than the superficial infections with Candida. So our superficial mycoses drugs can be a variety of topical or oral. For mild to moderate infections, topical agents are generally preferred. We do have specific indications for what we use against what, and that's in your table 79.5. Table 79.5 is something that I had something very similar to this when I was back in practice and just beginning to really help me figure out which drug goes to what, and I have to look these up all the time because this is not something I use every day. So this is a really good resource, I think, for y'all. Remember, ringworm is the popular term for dermatophytic infections, including Tinea pedis, Tinea curis, and Tinea corporis, and Tinea capitis. And the onychomycosis is a term for fungal infection of the toenails and fingernails. So dermatophytic infections, which we call ringworm, there are four principal types again. So Tinea pedis is ringworm of the foot or athlete's foot. Tinea corporis is ringworm of the body. Tinea curis is ringworm of the groin. And Tinea capitis is ringworm of the scalp. For Tinea pedis or pedis, that's one of the most common fungal infections and does really well with topicals. So think athlete's foot and the feet, so pedis. Patients should be advised to wear absorbent cotton socks, changing their shoes often, and drying their feet after bathing. Typically, this is from a wet, moist environment within your shoe. Some of the options then for treatment of that would be listed in that table. Next one is Tinea corporis, which is the ringworm from our body. It usually responds to a topical azole or allylamine. You should really have treatment for at least a week after your symptoms have cleared, and more severe infections can sometimes need antifungal pill antifungal agents. The Tinea curis, which is your kind of groin issue, does also do pretty well with topical therapy, and again, you should have symptoms treated, or you should have treatment for at least a week, even if the symptoms have cleared. Sometimes you also do need systemic antifungal. The Tinea capitis is difficult to treat. We most typically consider this a possibility in young children and newborns, but you do see it in adults. I feel like this is what maybe I see more in some of my nursing home patients. Topical drugs are not likely to work. Oftentimes you need to take an oral pill for 6 to 8 weeks. So we have the dermatophytic infections, which is the tinnias, right? Then we go into the candidiasis. One of the most popular and common is vulvovaginal, so a yeast infection in women. 75% of women will have at least one yeast infection in their lifetime. The majority, far and away, of these are caused by Candida albicans, and many also may be Candida glabrata, especially if you're immunocompromised, like HIV and AIDS. Factors that will predispose people to Candida infections, especially women, for these specifically will be pregnancy, obesity, diabetes, debilitation, HIV, or after certain drugs like oral contraceptives, steroids, anti-cancer agents, and then systemic antibiotics. With current drugs, just 1 or 3 days of topical therapy can be curative. In addition, oral therapy may be used. A single dose of 150 milligrams of fluconazole, which is diflucan, can be curative, but it can cause more side effects than the topical agents. For women with recurrent vulvovaginal candidiasis, weekly prophylaxis with oral fluconazole is highly effective, but relapse can be very common when treatment is stopped. Major drugs for uncomplicated vulvovaginal candidiasis are shown in your table 79.5. All appear to be equally effective, so drug selection is largely based on patient preference. People can have oral candidiasis, known as thrush. We use nystatin, clotrimazole, or miconazole. If they're immunocompromised, sometimes you give them oral fluconazole or ketoconazole. The onychomycosis, toenails, fingernail fungus, is difficult to eradicate and requires prolonged treatment. Infections may be caused by dermatophytes or by the Candida species. Because it's largely a cosmetic concern, treatment is usually optional. You can have oral antifungal agents or the topical cyclopirox. Success rates with oral therapy are quite low, and rates with topical therapy are even lower. It's pretty hard to treat. So for oral therapy, the drugs most often used are the terbinafine, which is Lamisil, itraconazole, which is the Sporanox. Both are active against the Candida species and dermatophytes. When in the body, these drugs become incorporated into keratin as the nails grow. Drugs may also diffuse into the nails from the tissues. They do have the possible side effects: headache, GI disturbances, abdominal pain, itching, or a rash. Typically, treatment with these can take 3 to 6 months, and sometimes even with prolonged therapy, the cure rate is low. So treating the onychomycosis is really challenging. The option for topical therapy is the cyclopirox, which we call Penlac Nalacor. It's one of the 3 topical agents available in the U.S., and otherwise we do use topical terbinafine or itraconazole. The issue with the cyclopirox is it's only active against one dermatophyte and no activity against Candida. To use the cyclopirox, it's applied once a day to the nails and the immediate adjacent skin. New coats are applied over old ones, and then once a week, all the coats are removed with alcohol. It doesn't seem to work very well, though. Then we have Tavaborol, which is an oxaborol antifungal medicine that treats the onychomycosis. Then we have the efinaconazole as well. Then we have all 12 members of the azole family that we can also use for superficial. Those are all listed in table 79.5. And remember, the azoles have a broad spectrum against a lot of pathogenic fungi, including the dermatophytes and the Candida. So they're really good agents. The other one is they talk about the griseofulvin, which is Grispeg. It's oral treatment for superficial mycoses. It does not work with systemic mycoses. It's interesting because the Grispeg is deposited into the keratin precursor cells of skin, hair, and nails. So because it's present, the newly formed keratin becomes resistant to fungal invasion. So as the keratin is shed, it's replaced by fungus-free tissue. So that's a pretty cool one to know. The Pauline antibiotics. The most popular one that we talked about was the nystatin, which is a drug I feel like we use quite a bit in practice. It's only used for candidiasis. It's the drug of choice for intestinal candidiasis and for candidiasis of the skin, mouth, esophagus, and vagina. It can be given orally or topically, and there's no significant absorption from either route. Oral nystatin can cause some GI upset. Then we have the allylamines. These drugs are listed there. The main one I want to mention is terbinafine, which is Lamisil. That's the one I see most in practice from me. It's very similar to the naftifine. Again, these are topical drugs, and then terbinafine is less active against Candida. So it's interesting because Lamisil is one of the ones that we use a lot over the counter, and it's really much better for ringworm than it is for Candida. So ringworm or the Tinea pedis is good for it, or the onychomycosis is pretty good for it as well. The next one is the butenofine, which is Lotrimin cream, and is another popular one as well. Then there's these other ones that are on there as well that we kind of already moved or talked about. The tolnaftate is Tinactin. If you think of the commercial, the fast-acting Tinactin is employed to treat a variety of the superficial mycoses. Really what I want you guys to know about the superficial mycoses, to break this down and keep it a little simple for you, is that if you're able to access table 79.5 to answer a test question, I think you'll be just fine. Kind of remember that we have the differences between dermatophytic infections and Candida. The most common Candida infection tends to be the vulvovaginal or oral. And then onychomycosis can be either dermatophytes or Candida. And that will wrap up chapter 79. As always, please ask, write, email, or reach out if any questions or concerns.